Okay, it's by my reckoning time to get this thing underway. To use the actual functions, you can hit the enlarge button above your screen on the top right, and that'll maximize the slide size. But if you want to get back to the chat facility, just hit escape on your keyboard, and you can then put your questions to Liz or comments in the chat facility. This is being recorded and will be available on the National Stroke Foundation's site, Inform Me, as well as the ASNEN site. And just a request, if you could return your attendance sheets back to my email address, which you'll have received courtesy of getting the invitations and the instructions. And so I'll now introduce Liz. So welcome to this ASNEN Professional Development webinar. I'm Patrick Root, and I'll be moderating this session. The ASNEN Steering Committee would like to thank Boehringer Ingelheim, the Stroke Society of Australasia, and Stroke SA for the generous support of the ASNEN initiatives. Thanks also to the National Stroke Foundation and the Victorian Stroke Clinical Network for helping promote our webinars, as well as to the NSF for making these recording sessions available via Inform Me. If you want to check out our website, it's www.asnen.org, where you can learn about any future education events that are coming up. So the topic for today is Stroke Mimics and Red Flags, presented by Liz O'Brien, who's an ASNEN committee member, as well as stroke nurse practitioner from the Royal North Shore Hospital in Sydney. Thanks, Liz.
Hi, thank you, Pat, and welcome everyone. For those of you who were at Smart Strokes in Canberra in August, this will be a repeat performance, but the fact that you've dialed in after already having seen it, I'll take as a compliment. Thank you very much. So today we're going to talk about a stroke is a stroke, or is it? Stroke mimics and red flags. So what we'll do today is we'll define stroke mimic and stroke chameleon. I set out when I first was doing this presentation and just looked at stroke mimic and stumbled across stroke chameleon, which I hadn't actually come across before. So it's a very interesting thing to sort of put into the mix. So we're also going to talk about why it's important to discriminate between a mimic and the real thing, so a real stroke or TIA, and the importance of that in regards to acute presentation and management, and for those patients who present who may be thrombolysis candidates. So we're also going to talk about some common signs and symptoms and what are the clues to being a stroke mimic, and then we'll go through some common examples of stroke mimics and stroke chameleons. So when a patient presents to the emergency department or into your clinic, you will need obviously to do an initial assessment. So what we look at is that a sudden loss of brain function, focal brain function in a vascular territory is the main feature that we look at for the onset of stroke. Patients with conditions other than brain ischemia may present in very similar fashion. Patients who present suffering a stroke can also present with other serious medical conditions. So you need to do your initial evaluation rapidly but very broadly. So our goals in the initial phase include ensuring that the patient is stable medically and particular attention to airway, breathing and circulation. We try and quickly reverse any conditions that are contributing to the patient's problem and determine if these patients with acute ischemic stroke are candidates for thrombolytic therapy, and then also moving towards uncovering the pathophysiological basis of the patient's neurologic symptoms. So what is a stroke mimic? A mimic is to resemble closely or to simulate and to take on the appearance of and to imitate. So a stroke mimic is someone with a non-vascular disease that presents with stroke-like symptoms that are often indistinguishable from stroke. And approximately 20 to 25% of stroke mimics make up our suspected stroke presentations. And on a personal note, in our TIA clinic at Royal North Shore, in our first 2 years, we had a 39% mimic presentation to our TIA clinic. So If you look on Up to Date, you can get a huge array of neurological presentations that present with stroke-like symptoms and are classed as stroke mimics. So we'll go through some of those, but won't have time to go through all of those. They're there for your perusal. So what is a stroke chameleon? So these are strokes with atypical presentations that take on the appearance of other disease processes. For like chameleons, they are disguised strokes that can change and evolve with time. And if you have a look in my lovely picture there, you'll try and pick out my lovely green chameleon. So stroke chameleons can present very interestingly. So someone with a persistent acute global amnesia will actually have bilateral thalamic stroke. Someone who you think might have a focal epilepsy can also have a limb-shaking TIA. Peripheral nerve lesion presentation, when you do an MRI, may very well present as a cortical stroke. Or those patients presenting with confusion and delirium would have possibly have bilateral occipital stroke. So a stroke chameleon is an atypical presentation of stroke, and these patients can also present with movement disorders. An acute hemipalismus can result from an infarct of the subthalamic nucleus. Patients who present with dyskinesias, whether it be hyper or hypokinetic, can be found with ischemic lesions at the motor cortical or subcortical regions. Patients presenting with confusion, agitation and delirium can have lesions in the limbic cortex or orbitofrontal region. And sensory deficits with paresthesia or loss of sensation can occur with parietal and thalamic stroke. So what are some of the features that you need to be on the lookout for, and the red flags that might start you thinking twice about, what really is the diagnosis of the patient that's in front of you? So age is a very common red flag. So those patients who present who are young, it's less likely that they will present with TIA and stroke, but certainly not out of the question, so it shouldn't be discounted. The duration of the symptoms, if the symptoms are rapidly resolving, or if they're reoccurring in very much a similar nature, then you might have to think twice about whether or not they're stroke or TIA. The nature of the symptoms, whether the symptoms themselves are positive presentation or negative, and we'll talk about that a little bit further in the next slide. Thinking about what some of the precipitating factors are for your patients. Is there alcohol involved, drugs? What are their risk factors that might make you think about? And the onset and progression of the symptoms. And this is where you think about, are the symptoms sudden or are they stepwise? And that's very much something that we'll go into as well a little bit further down the track. And thinking about some of the other associated symptoms that our patients present with. Do they have a headache? Have they had a loss of awareness or consciousness? Does it happen during or after their onset of symptoms? So moving on to the positive symptoms that I mentioned. Positive symptoms indicate an excess of central nervous system neuron electrical discharges. And this is where the patients can present with visual symptoms such as flashing lights, zigzag shapes, lines, shapes and objects, or somatosensory symptoms of paresthesia and pain, and motor symptoms where they'll present with jerking limb movement. On the other hand, we have negative symptoms. These indicate a loss or reduction of central nervous system neuron function, so things like loss of vision, loss of hearing, sensation and limb power. So when you think about migraine and seizure, these presentations are characterised with having positive symptoms. And if you look at the positive symptoms that I just mentioned above, then you will definitely see some of those symptoms that we would see in someone with migraine and seizure. Whereas TIA and stroke present with negative symptoms. So that's obviously loss of vision, changes in sensation and obviously loss of limb power. Loss of consciousness is something else that you need to take into consideration. So this is very common in seizures and those patients presenting with syncope, but it's uncommon in TIA and stroke. Some of the precipitating factors that you need to keep in mind. So someone with a seizure, these seizures can be precipitated by alcohol excess, illicit drugs, sepsis, hyperventilation, non-compliance with their anti-epileptic drugs. Hypoglycemic patients can also present with non-specific symptoms, but these can include fatigue, dizziness, visual disturbances, drowsiness, dysarthria, and a lowered mental state, a depressed mental state. And this can proceed to seizures or coma if not corrected. Patients presenting with electrolyte imbalance, such as hypo or hyperkalemia, hypo and hypercalcemia, hypomagnesemia, hypophosphatemia, can cause generalized or focal muscle weakness. And sepsis patients present with malaise and generalized weakness. All things to keep in mind. So what are the predictors of a stroke mimic? So those symptoms that would increase the odds of a patient presenting with a stroke are abnormal eye movements, a higher systolic blood pressure, an increased diastolic blood pressure of greater than 90 millimeters of mercury, and a history of atrial fibrillation or angina. Whereas on the other hand, the increased odds of a stroke mimic would be decreased loss of consciousness, level of consciousness, normal eye movements, a cognitive dysfunction, and unfortunately girls, it's not on our side, so females have an increased odds of being a stroke mimic, and those at a younger age. One question that often comes up when we're thinking about our patients presenting to the emergency department and whether or not they're a stroke mimic is the safety of IV thrombolysis in those patients. So there was a group in the United States who looked at their patients in a prospective single-centre study in 2015, and they looked at the safety of TPA in stroke mimics. So 14.5% of their TPA cases were stroke mimics. They had a 1.3% fatality, which meant to them one patient who had encephalopathy with uncontrolled hypertension versus 1.13% complication in a confirmed stroke. They only had 2 minor extracranial hemorrhages. So they also, in their study that I have put in here, they looked at a meta-analysis of 8 other studies, and they showed that there was a decreased risk of symptomatic intracerebral hemorrhage after IV TPA in stroke mimics, and these patients also had a favourable functional outcome, and they usually were discharged with a modified Rankin score of 0 to 1. So their study indicated that IV TPA does not adversely affect the favourable natural history of stroke mimics, and the treatment benefit would not be counterbalanced by the potential for harm to patients presenting with stroke mimic. So when we think about the patients that present with a stroke mimic, who are the ringleaders? And no, it's not Tom Cruise, but when I was researching this, when you type mimic into Google, up comes all these pictures of Tom Cruise in the movie Edge of Tomorrow. The aliens were called mimics, so I thought I'd just pop that in for your amusement. So anyway, so the major patients that we see with stroke mimics are those who present with migraine aura. These patients have progressive neurologic deficit that completely recovers. It occurs before the onset of migraine headache, and these symptoms can be visual, sensory, motor, or speech. The headache is usually simultaneous or just after the end of the aura, but it rarely occurs an hour or more after the aura. You can also have an aura with minimal or no headache. These symptoms usually resolve within 20 to 30 minutes, lasting seldom more than an hour. The migraine aura often progresses slowly in one modality. So the patients may often describe to you scintillations or bright objects that move slowly across the visual field. They may describe a paresthesia that can progress gradually from one finger to all, to the wrist, to the forearm, to the shoulder, the trunk, and then face and leg. And this occurs over minutes. And this is the stepwise progression that I mentioned earlier when we were talking about symptom onset. And then after these positive symptoms move, they can then be followed by loss of function. So the visual scintillations can end in a scotoma or a visual field deficit, or the paresthesia can leave the area of skin numb. So therefore we have our stroke mimic. And these presentations are often recurrent or stereotyped. When you're taking the history from your patient, you may often hear them say, oh, look, you know, I've got a history of migraine, and yes, it happens exactly the same. And, you know, and you'll hear the same story having happened a number of times previously. So it makes you think that the patient may actually be a stroke mimic. So a seizure can also present as a stroke mimic. These patients may have a post-ictal hemiparesis, a Todd's paralysis, and they can also present with aphasia or neglect. The seizure can cause neuronal dysfunction that can manifest as weakness, aphasia, confusion, or sensory symptoms. The Todd's paresis can cause a unilateral hemiparesis. It's usually localized to one side. It can last for 20 minutes, but it can then continue for up to 48 hours. And we see this in about 13% of patients who present with seizures. So to keep in mind with seizure, it's an abrupt onset with positive features in a single functional neurological domain. And again, it's often recurrent and stereotyped. Syncope patients are often referred through the ED as well. So these patients present with abrupt and transient loss of consciousness. They can have an absence of postural tone, but they usually have a rapid and usually a complete recovery. This is caused by an interruption of energy sources to the brain, and it's usually caused by a sudden reduction of cerebral perfusion. Some of the common types of syncope that we see are neurocardiogenic or vasovagal syncope, situational syncope. So we see this with patients during or immediately after urination, defecation or swallowing, and then orthostatic syncope. And this is usually associated with orthostatic hypotension. And you can have syncope related to cardiac ischemia or cardiac arrhythmia. So in these patients, ECGs and Holter monitors are very important. One of the very common patients that we see as a stroke mimic are those with vertigo. So these patients present with a benign positional paroxysmal vertigo. Another diagnosis they get is labyrinthitis and also vestibular neuritis. They present with an isolated dizziness, which is usually a peripheral vestibular disturbance. Only 3% of true stroke patients present with dizziness plus additional symptoms, and 1% with lone dizziness. This dizziness or vertigo is usually movement induced. It can last up to a few weeks, and the patient has normal MRI imaging. What we can see is a positive Hall-Pikes and head impulse test, which can distinguish between the peripheral lesion and a central cause. So when you're doing the Hall-Pikes or head impulse test, you can induce a nystagmus, which is indicative of a peripheral lesion. There are some lateral medullary or lateral pontine and inferior cerebellar infarcts that can mimic the clinical symptoms of vestibular neuritis. So here we have a stroke chameleon. Nystagmus in an acute cerebellar stroke has the fast phase toward the side of the lesion. It's a great picture, isn't it? Leads are some other stroke mimics that we need to eliminate as soon as possibly with the use of CT scan. It highlights the importance of rapid assessment and imaging in these patients. So patients presenting with subarachnoid hemorrhage have a sudden onset of severe headache, which is the most common presentation. It's accompanied by loss of consciousness, seizures, nausea, vomiting, and meningismus. And they have lateralizing signs, or lateralizing signs such as unilateral weakness are uncommon in subarachnoid hemorrhage presentation. Patients presenting with a subdural hematoma, especially in the posterior fossa, present with symptoms of elevated intracranial pressure, including headache, vomiting, anisocoria, dysphagia, cranial nerve palsies, nuchal rigidity, and ataxia. Cerebral hypoperfusion due to increased intracranial pressure or mass effect can culminate in cerebral infarction. Global deficits such as disturbances of consciousness are more common than focal deficits after subdural hematoma. Tumours are seen occasionally. We've had a couple in our TIA clinic presenting as stroke mimics or TIA mimics. The tumours are usually a slowly increasing mass, so they have progressive syndrome. Patients with brain tumours presented to ED in this study by Fernandez, they saw it was about 6% of their presentations who presented with stroke-like symptoms lasting less than 1 day. And this can usually be more indicative of hemorrhage into the tumour or those developing obstructive hydrocephalus because of the tumours. Transient global amnesia we see quite often, and I've mentioned that earlier in the chameleon table. But it's characterised by transient loss of anterograde memory. It can last for a few hours. Thank you, Susie G. I'll try and speak up louder. It can last for a few hours. There is filling of old memory and new memories will occur, but there is a gap in the memory during the event which persists. It does not actually resolve. Procedural memory is intact, so the people are able to do what, their normal activities. However, repetitive questions are very common. Vascular risk factors are very important. The actual etiology of transient global amnesia is not quite understood yet. However, because we do sometimes see small pinpoint diffusion-weighted image lesions in the hippocampus on MRI scan, we do actually treat these patients as vascular patients and treat their vascular risk factors such as cholesterol and hypertension. And the good news that you usually can share with your patient is that it rarely reoccurs. Some other spinal pathology that you will see, especially in patients presenting acutely to the emergency department, is presentation with acute flaccid paralysis. This is normally a presentation of bilateral limb weakness, sensory deficits with a discrete level below which sensation is absent or reduced, and bladder function can be impaired. And these patients can present with spinal infarcts, anterior spinal artery infarcts. These patients can also present with a unilateral weakness, which again would make that a little bit more confusing when it comes to our stroke mimic presentation. They may have Brown-Séquard syndrome or a transverse myelitis. Patients can also present with a compressive myelopathy from neoplasms. Epidural or subdural hematomas or abscess is the most important category of diagnosis to exclude. These often require urgent surgical decompression. These lesions typically develop over time, and sometimes the clinical presentation can be fairly abrupt and mimic spinal cord infarction. But these are the patients that you really need to be very careful with as well when we're thinking about acute treatment. So some of the tricky patients that we see who present as mimics are those with a functional diagnosis. They often manifest as an acute weakness or a sensory disturbance. Frequently there is a trigger to the presentation, so a panic attack or a dissociative episode. One of the guiding principles when you're seeing someone with a functional disorder is that there is inconsistency during the physical examination. So when you're examining them, they may have no ankle plantar flexion while they're lying down, but they can stand on their tiptoes when you ask them to walk across the floor or do something else for you. There is a task-dependent weakness. So they have an inability to move their arm during the examination, but they can use their arm to take something out of a bag or to put their shoes back on. So again, it's important to watch what your patient does when they walk into the room and when they're just doing things with you during the examination. A positive Hoover sign as well, and that will come up on the next screen, and we'll talk a bit more about that when it comes up. Patrick, you're asking, what is dissociative episode? I think it's when someone feels, actually I can't actually put a name to it, but when they don't feel like they're quite themselves, I think more than anything else, and I think it really does come with panic attacks and anxiety as a cause, which would then make them, sort of react. There's a reactive presentation. So an incongruity with recognised neurological disease as well. So when you're looking at someone and the symptoms and the presenting signs just don't add up, then you can start thinking that the patient may be presenting with a functional problem. However, you can't discount what the patients actually present to you with, because they can often have underlying disease or a disease that manifests later. So this is the Hoover sign for functional leg weakness. So when you're asking them to push down with their right heel, as you can see in the image A, they actually, you ask them to push down with their right heel, there's no effect with that part of the examination. So the hip extension is weak, if you would leave that with that examination. However, when you ask them to lift their left leg, their right hip extends down at the same time. It's a bit difficult to explain, but when they lift their left leg, the right hip extends, and so the hip extension is normal on that right side if they were complaining about a leg weakness. So another presentation for someone with a functional disorder is that functional facial symptoms with contraction of muscles which cause jaw deviation. So this can lead to an appearance of weakness, even though it's caused by muscle overactivity. So it's like when you're trying to explain to someone what a facial weakness looks like, and you try and do it yourself. It's pretty well, if you look in the mirror, that's what you would see. And sometimes an acute presentation of this can lead to a diagnosis of stroke. Someone who reports being blind, so a cortical blindness, but has normal pupillary reflexes and preserved optokinetic nystagmus. An MRI with these patients may reveal bilateral occipital pathology, which causes the cortical blindness. However, a small subset of patients can, with cortical blindness, think they can see what they cannot see, and this is Anton syndrome. So just you still need to do investigations for these patients who say that they actually have a loss of their vision because there may be something underlying. Patients with cognitive symptoms often present with as a functional diagnosis. They will have impaired fluency. They can jumble their words when they're speaking. They can have word finding difficulty. They can have a marked loss of remote autobiographical memory. They have an inability to perform overlearned skills, such as reading, spelling, or simple arithmetic. They have an ability to perform complex, implicit cognitive tasks in the presence of poor performance on simple tasks. And their performance, as we said earlier, is inconsistent with observed behaviour and at different points in the examination or across repeated evaluations. Sometimes these symptoms can also be attributable to anxiety or depressive disorders. So some of the management and ongoing care for these patients is prompt diagnostic testing to confirm or negate the diagnosis. Explain to these patients that what they do have is a functional weakness, your nervous system is not damaged. And I think that's the important thing, is saying that there's no damage. Indicate that you believe the patient, because they believe that. Explain that what they don't have. So you would explain to them they don't have a stroke, and you've got the imaging behind you as well to prove that. It's very common, it's reversible. There's lots of self-help and written information available. For some cases they may need a psychiatric referral, and this website, www.neurosymptoms.org, which is a functional and dissociative neurological symptoms a patient guide website, is excellent to direct the patients to. There are lots of different things that they can choose from in regards to their symptoms or what they're experiencing, and it gives them some management techniques and that self-help that might help them through. So I thought I would just also put in a couple of case studies that we've seen in our TIA clinic that made us think. So this first case is a 42-year-old female. She presented with an acute onset of right arm heaviness. She was unable to pick up the phone. She felt flushed and dizzy. She was quite pre-syncopal. She was ataxic, she was dysarthric and had difficulty swallowing, and the symptoms lasted 4 to 6 hours. And it was preceded by a migraine that morning, which was relieved with Methindol and sumatriptan. It, however, recurred later that day. She had also experienced these similar symptoms twice in the previous week, lasting about an hour and a half or 4 hours. Her past history, there was no hypertension. She had some preeclampsia when she was pregnant with her first child, no diabetes. She was quite a heavy smoker. She was having very regular migraines and a significant alcohol intake and very stressful work. So we were thinking very much complicated migraine. She had a very significant history. Sent her for an MRI, and this showed an acute to subacute infarction within the deep penetrating branch of the left middle cerebral artery. So the symptoms were a constellation of things that were very stroke-like, but also very migraine presentation. So it just goes to show that you need to make sure that in presentation, you work these patients up appropriately and make sure that you get an idea of exactly what's going on. So the second case is a 73-year-old female. She had an episode of expressive and receptive dysphagia. She had ongoing mild alexia where she was unable to do some task-like things. She had very odd behaviour. And we were thinking that there was, was it TIA or was it functional? She had trouble reading, and her MRI came back with this quite significant intraaxial mass lesion in the left temporo-occipital region. It most probably was a glioma. So she was referred on appropriately for management of that. So again, we thought that she was just a bit odd, possibly functional, and she ended up with a tumour. It just makes you think. So some of the take-home messages are that you need to have a discerning review and investigation of presentations to ascertain if patients presenting stroke or stroke mimic. You need to review the eligibility for acute treatments. Thrombolysis in stroke mimics has a relatively small risk, and stroke chameleons can miss out on potentially beneficial stroke treatment if not assessed and managed appropriately. Thanks everyone for listening, and I'm open to questions.
Thanks, Liz, for that great presentation. I think it was at 39% at your TIA clinic.
Yep.
That were mimics.
Yes.
That's quite extraordinary, really, isn't it?
It was.
And is that something that's an ongoing percentage, do you think, around about that area?
Possibly. I mean, since we actually reviewed that information, we also added another clinic to our neurology service, a rapid access neurology clinic. So if we were to go back over our information now, like in the last couple of years since that clinic's been opened, a lot of the BPPVs and labyrinthitis and seizures would probably be taken away from our clinic and in their clinic. So it's probably a little bit less, probably back to normal. But we still see those patients, quite a few present with migraines. And we still see a few vertigos because the thought is that these patients may be posterior circulation TIAs, and we need to make sure that, we fully investigate that. But it would probably be a little bit less, if not the same.
Yeah, sure.
Yeah.
And I suspect that some of the ones that end up being mimics may be coming from sites or practices that don't necessarily see a lot of strokes either.
Yep, that's right. And also because I also think we have a very big emergency department, and I think a lot of these patients before we had these clinics would be referred back to the GP for some type of management, and I think this is a good way to make sure that patients are seen and evaluated, and get a good workup before you know, saying, oh, well, it's nothing, or it's functional, or it's this, or it's that. You know, we actually can provide them with a little bit more.
Yep, get to the bottom of it fairly quickly.
Yeah, that's right.
Yeah, excellent. There's a question there from Lisa.
Yep, Lisa has asked, any thoughts about why females are more likely to have mimics? Is it to do with prevalence of migraine? I'm really not sure, Lisa. I think that it could be to do with migraines, because a lot of migraines are very much hormone related around the women's cycle. We see a lot more migraines and quite severe. So yes, it could be to do with the hormonal exposure more than anything else. But if I find out that answer, I'd certainly let you know if it was anything else. Hopefully that's all it is, and no other meaning behind it. Thanks, Louise J. Any other questions? Jacqueline B. Is it worth doing MRIs on all query TIA patients, given the high percentage that aren't TIAs in rural areas with no clinic? That's a difficult question, because again, I think I can understand it's difficult in rural areas where the services, the MRI availability is not there. There's no clinics. We are very fortunate in that we are able to provide a certain number of MRIs for our patients here. But even then, I still struggle to get enough MRIs for all the patients that we see. And I think you do have to be a bit circumspect about, do these symptoms really sound like a definite TIA? And what is the management of that patient going to change, because of the result of the MRI scan? So obviously, management would change if you've got someone who you think is a migraine, and then they end up with a stroke, like my patient there, or a tumour. So, but that's really difficult to answer, and I think you often have to go with your guts. So Louise J has said, our telehealth TIA clinic do MRIs based on the assessment by neurologists. So yes, so Louise, you're backing up what I'm saying, is that it's very much dependent on the patient presentation, their symptoms, their risk factors, and what you actually feel about what's actually happening with that patient. So yes, I totally agree.
Thanks again, Liz. Just seeing now if there's anyone else typing a question. If you have a question at the tip of your tongues, guys, or your fingers, type it in now. We have got plenty of time, so plenty of time for questions. So we'll just give it a moment there, Liz, and see if anyone else comes up with a question.
Yeah.
It looks pretty quiet, but look, thanks again. Yes, but thanks for this presentation on behalf of ASNEN, and just to let everyone know that, again, that it's recorded and it's available for revisiting on our website, as well as the National Stroke Foundation's Inform Me. So please, if any of your colleagues wanted to make it but couldn't, let them know that it's recorded and will be available, probably in the next week or so.
And if anyone's got any questions that comes to them later, most of you will have some availability to my email address, or you can find it or send it through Pat, through the ASNEN email. I'm happy to answer those questions or chat on the email if anything comes up.
Great, Liz. I'll make sure I forward anything on if questions come in. Thanks everyone for dialing and logging in. That'll be the last webinar for this year, but we hope to do 3 or 4 next year, and we hope to see you at the stroke conferences during next year as well. And please send in those attendance lists with anyone's contact details if they want to be added to the ASNEN email distribution list. Thanks again.